collaborative approaches in tobacco cessation. On behalf of the Department of Psychiatry, I extend a very warm welcome to our respected dignitaries, faculty members, moderators, presenters, postgraduate students, and all the members of the audience. I now invite our respected Dean Sir, Dr. Satish Ghosh, to address the audience.
Good afternoon, all the faculties and the postgraduate gathered here. Basically, as you know, the purpose of this meeting is to break the silos of the department. You may think why I should attend the presentation by the Department of the Psychiatry. And basically, as you know, to know what is happening in your field, you will not have to depend upon your department academic activities. What I mean to say is that departments, faculties are there to guide you and all these things. For knowledge purpose, the knowledge is in your hand, right? So, but what we need to improve is what is happening in the other department, right? So, this gives an platform to find out, to give the scope to all the department, what they are doing it and what is need to be done. In general, right? So, of course, sometimes it may be the department specific, but sometimes we feel that we also need to know what is happening in the other department. That is the purpose with what this meeting has been started. And as rightly pointed it out, and this meeting was started in the month of January, and now successively we are running for the month of July, that is 7th edition is going on. And the importance of all of us know the current situation, the importance of the psychological health or the mental health. Everybody, I think all of you are aware of what is going on in Delhi, right? So we also keep on getting circular from government of ministry and all these things like mental health need to be taken care of and all these things. So keeping in that mind, I thought it's the right time that the Department of the Psychiatry should be given a chance to sensitize both the faculty and the PGs, the current scenarios and what is the background in it and what best can be done, how we can deal with in the day-to-day activities. So with this background, I just request the Department of the Psychiatry to start. At the end, I have some announcement that I will make.
Good afternoon to all. On behalf of the Department of Psychiatry, I wish to thank Dean NCRL and Dean Academics also for giving us this opportunity to host the academic grand rounds for the month of July. Now, we have planned the content for this program very carefully. We have reviewed the program content in the last 6 months and we received the guidance from the Dean Sir also. And we believe that for the program to be meaningful to a mixed specialty audience like this, the topic should emphasize on collaboration and specifically collaborative care. So you'll find that there is a thread of clinical cooperation that runs across all the topics that we have selected for today. So we hope that that makes it extra meaningful and relevant to all of you. So we have 3 sessions and each session will last around 15 minutes followed by 5 minutes of Q&A. Hopefully that we can all engage you well enough. So we hope to be able to meet your expectations and we hope that you will find the content academically enriching and clinically relevant and appropriate also. So thank you for your time and participation. Over.
Now moving on to our first session. Traumatic brain injury and alcohol use disorder can each independently contribute to significant cognitive and behavioral difficulties. When they coexist, the clinical picture becomes more complex, posing important challenges in diagnosis, assessment, and management. The first session will explore these challenges and the clinical approach to such a patient. The case presentation titled as Post-TBI Neurocognitive Disorders in a Patient with Eye Overuse Disorder, Challenges in Diagnosis and Management. Now I invite Dr. Hemshri, second year postgraduate resident from the Department of Psychiatry, to present the case illustrated through the case report.
Good afternoon, respected chairpersons, distinguished faculty, and my dear fellow colleagues. I am Dr. Hemshri from the Department of Psychiatry. Today we would like to present a case of post-TBI neurocognitive disorder in a patient with alcohol use disorder. This case demonstrates how psychiatric assessment alters the diagnosis, management, and rehabilitation of this particular case. And we would also like to highlight the challenges we faced in the diagnosis and management of this patient. Before discussing the case, I would like to briefly introduce the role of consultation bias in psychiatry. Consultation bias in psychiatry or licensed psychiatry is a subspecialty of psychiatry concerned with the assessment and treatment of psychiatric disorders and psychological distress in patients with medical and surgical conditions. It can be described within the biopsychosocial model which was proposed by George L. Engel, which encompasses the interaction between the biological, psychological, and social factors in health and disease. Consultation bias in psychiatry can be practiced in several models depending on the healthcare setting and the availability of resources. In our particular setting, we practice this in 4 major models. The first being the outpatient consultation model, where the patients attending other specialty outpatient clinics are referred to psychiatry for evaluation and management of their psychiatric comorbidities that may influence the course of their medical diagnosis. Second type is the inpatient consultation model, where the patients who are being treated under other departments as inpatients are where the other treating parent department formally requests a psychiatric opinion for patients hospitalized under them. And the third type, where the patient is taken over by the psychiatric team from the parent department for the management of acute psychiatric conditions. And the fourth type, where we lodge in patients from other departments under the psychiatry ward while the patient is still under the primary care of the parent department. Common reasons for psychiatric referrals in hospitals are altered mental status, self-harm, substance withdrawal or intoxication, medically unexplained symptoms, psychiatric symptoms secondary to medical illness, and capacity assessment. This case exemplifies the liaison approach where continuous collaboration between neurosurgery and psychiatry influence the diagnosis, management, and treatment of this particular patient. The patient's clinical course can be divided into 4 distinct phases. Phase 1 being the phase of emergency surgical intervention. Phase 2 of critical ICU stabilization and monitoring. Phase 3 of managing infectious and metabolic complications. Phase 4 of management of neuropsychiatric transition and cognitive rehabilitation. A 36-year-old male construction worker, educated up to 9th standard, belonging to a Tamil-speaking Hindu family, presented from Kadalur. He met with an RTA under intoxication on 11th of March 2026 and he sustained head injury accompanied with loss of consciousness of unknown duration. He was then taken to a nearby GH where CT brain was done. From there he was referred to MGMCI. Upon receiving the patient at EMS, he had a GCS score of 11 with intact airway, breathing and circulation. Following which the patient underwent imaging which showed multiple hemorrhagic contusions in the bilateral frontal and bilateral temporal and left parietal regions. After which the patient underwent bifrontal decompressive craniectomy and bifrontal contusectomy under GA on 12th of March 2026. This is the post-op CT of the patient. After the surgery, the patient was on mechanical ventilatory support during the acute postoperative period. The patient was gradually weaned off the ventilatory support and shifted to neurorehabilitation ward, where he developed fever secondary to a possible infection. He also developed hyponatremia, which was treated with tolvaptan. However, on day 16 of admission, it was noted that the patient developed some behavioral changes, after which The patient was referred to psychiatry with complaints of agitation, confusion, disorientation, self-harm attempt by consumption of a hand-drip solution with water. Patient was taken over to the Department of Psychiatry by the Department of Psychiatry on the same day upon receiving the referral, and the following salient features were noted. Patient had an 18-year history of alcohol use with increased use in the last 6 months. Last use being the day of trauma. He also had 15-year history of tobacco use with increased use in the last 6 months. Last use being the day of trauma. He also had history of deliberate self-harm 15 years ago, and history of alcohol withdrawal seizures 4 years ago, and history of RTA under intoxication with no significant head injury 2 years ago. The patient presented with 3 days duration of complaints of agitation, confusion and disorientation. Patient also had an alleged history of deliberate self-harm attempt by consumption of hand-drip solution in neurosurgery ward. No features suggestive of psychosis, mood disorder, amnestic disorder were noted. No history suggestive of jaundice, bleeding diagnosis or gastritis. Patient did not have any other medical comorbidities or any past surgeries. There was also history of alcohol use and dependent pattern in his late father. On examination, the patient was found to be conscious, disoriented to time, place, person. Patient also had healed surgical scars over the scalp and temporal regions. Vitals were found to be stable at the time of examination, and the patient was found to be underweight. CVS, RS and per abdomen were within normal limits. On the same day, a comprehensive neurological examination was performed, and the patient was found to be conscious. Attention could be aroused, and the patient was able to write his name and put his signature. However, the patient was disoriented to time. He had consistent misnaming of place and person, mimicking delirium. Patient also had immediate, recent and remote memory that was impaired. Further, formal cognitive language testing was not possible at this stage because the patient was speaking unintelligible phrases. On CNS examination, it was found that the patient had impaired sense of smell, and cerebellar spines were also found to be impaired. On mental status examination, it was noted that the patient was moderately groomed. He was fidgety with increased psychomotor activity. Rapport was not established. Patient would frequently try to get out of bed and ask for tobacco and alcohol using sign language. The affect was found to be irritable, and the patient would speak incomprehensible words. It was not goal-directed, and he had increased tempo and paraplegia. Thought and perception could not be assessed reliably at this stage. Ward behavior. The patient had nighttime restlessness. He would also search for babies in other patients' cabinets on the bedside of other patients, thinking that they were alcohol. Following this, considering the patient's cognitive status and behavioral symptoms, comprehensive language assessment was done. There, the patient was found to be right-handed. He had grossly intact speech with incomprehensible phrases. Fluency was intact, but patient had jargon aphasia. Writing was intact, phonation was intact, dysarthria was absent. However, the patient had impaired comprehension, impaired naming objects, impaired repetition, and impaired reading. On lobar function test, it was noted that the patient had predominant prefrontal cortex dysfunction with impaired working memory, cognitive flexibility, and abstract thinking. Patient also had impaired recent memory and visual memory. Patient also had language deficits in comprehension and naming, and the patient also had color agnosia and object agnosia. On Adam-Brooks cognitive assessment, the patient scored 42 out of 100. The patient was initially diagnosed with severe traumatic brain injury, bilateral frontal contusions with mass effect, right frontal and left temporoparietal subdural hematoma, post bifrontal decompressive craniectomy with bilateral frontal contusectomy, and right. An additional diagnosis of delirium, alcohol-induced delirium, secondary neurocognitive syndrome, and aphasia was made by the CLP team. Laboratory assessment. Patient at the time of presentation had a HB of 8.2, which was gradually corrected, and the patient attained a HB of 11.8. Patient also had severe thrombocytopenia, which was gradually normalized. He also had monocytic normochromic anemia and hypoproteinemia and hypoalbuminemia. Patient also had moderate hyponatremia with the lowest reading of 128, which was subsequently normalized, and he also had transient hypokalemia, which was corrected. The goals of the management in this patient was to treat the neuropsychiatric symptoms, treat substance use, and enhance the cognitive functioning and overall quality of life. And in order to do this, the patient was initially started on the suicide risk management protocol, and this was followed throughout his stay in the hospital. The patient was also started on antipsychotics olanzapine and chlorpromazine to manage his agitation. The patient was started at a dose of 5 mg olanzapine, which was gradually increased up to a current dose of 20 mg. The patient was also started on chlorpromazine, which was started at a dose of 100 mg, which was gradually increased up to 300 mg during the second week and gradually tapered and stopped on improvement. Mood stabilizer sodium valproate was started at a dose of 200 mg, which was gradually increased up to a dose of 1500 mg. The patient was also started on lorazepam 2 mg in view of agitation, which was gradually increased up to a dose of 10 mg and gradually tapered to 4 mg. Substance use management was done using Nicotex patch. The patient was started at a dose of 7 mg, which was gradually increased up to a dose of 14 mg. Naltrexone was started at 50 mg, which was gradually increased up to a dose of 100 mg. And thiamine and Numens were also started. Cognitive enhancement, for cognitive enhancement, the patient was started on donepezil and lamantine, and psychological interventions such as cognitive retraining and home-based cognitive tasks were also suggested and followed. On discharge, the patient was continued on olanzapine and donepezil and lamantine. At the time of psychiatric takeover, the patient had significant delirium, which was found to be absent at the time of discharge and the subsequent follow-ups. The patient also had a significant agitation at the time of takeover, which gradually subsided and was absent at the time of follow-up. Patient also had significant risk of self-harm at the time of takeover, which was absent at the time of discharge and thereafter. Patient also had craving for alcohol and tobacco, which gradually subsided, and now at present at follow-up the patient remains abstinent from alcohol and tobacco. Aphasia was also found to have improved during the hospital stay, and amnesia was also improved. Post discharge, the patient subsequently underwent a bifounded cranioplasty using customized titanium plate, and there is a CT of the same. So the challenges faced in this case were that we had assessment of delirium in a patient with language disorder. So the patient initially appeared delirious because he was constantly misnaming people, places, but structured language testing and showed impairment in naming, repetition and comprehension, which suggested Wernicke's aphasia. So this could have easily masqueraded the symptoms of delirium. There was also challenges in assessment of suicide risk in patients with secondary neurocognitive syndrome. This was because it was extremely difficult to assess the patient's suicidal intent. It was also challenging because the patient had multifactorial delirium, which could have been caused by the metabolic status of the patient, or the head injury, or the alcohol use. He also had trouble delineating substance craving from delirium, which was again a challenging process. And there was also challenges in the assessment and management of craving in this patient with neurocognitive syndrome. We would also like to extend our sincere gratitude to the Department of Neurosurgery for their timely surgical intervention, comprehensive perioperative care, and continued collaboration which made the patient's early recovery possible. Thank you.
Other members of the team played a role too, and we also would like to thank our neurosurgery colleagues who are leading our hall. So we invite questions from the audience, and we will do our best to handle your queries. Any questions from the audience?
the long term, because I don't know, like a history of alcohol, 15 years, addiction of 15 years, what is the long term rehabilitation plan was advised? At the time of, I think, hard follow-up, he was abstinent from the alcohol and all this thing. But do you think that he, like, what post-operative or the post-discharge follow-up is planned, and how we are going to follow up this patient?
So we had already, at the time of discharge, we had tried to manage both the substance cravings, both the alcohol use and tobacco use. So the patient was started on Licotex patch for the tobacco use, and the patient was also started on naltrexone as a measure, anti-craving measure. And the patient to date is being continued on naltrexone. Apart from this, the patient is also undergoing supportive counseling and motivational enhancement therapy for the same on a weekly basis.
We have a, like, from the hospital basis follow-up, like how patient is doing. Suppose patient is not doing that,
Yes.
that type of follow-up.
We do get back to the patients.
In the context of substance use, we have a social worker in the department, and one of her roles is to liaise on with the patient, and she actually tracks follow-up dates also. So they won't turn up for follow-up and attend the follow-up day. She places a call. Dr. Karthik, would you like to add anything to the presentation?
So I think it's a fine presentation, sir. And then we have to emphasize that collaboration, which has happened right from the start of the admission process, from the surgery team and to the psychiatry. And we had a number of referrals which we have sent to general medicine, to ophthalmology, to see for other scars and other surgical management. One postscript I wanted to add is like about the naltrexone part. The patient was discharged, this happened after the discharge. And after the discharge, he has undergone the post-op cranioplasty. And the anesthetist team has noted that the patient is on naltrexone, an opioid antagonist. Now they are supposed to give opioid analgesics for pain relief. So they promptly called us just before the surgery that this patient is on naltrexone. We know the washout period of naltrexone, we have to stop naltrexone. So instantly we couldn't answer, but then when we went back to the literature, it was saying anywhere it's 48 hours to 1 week time. So we safely stopped the patient surgery immediately. And then after the washout of period, he was again taken up for surgery. So this is also an anesthetist team also was involved in this post-op, which I want to stress here. Thank you.
Are there any other questions from the audience? Anything from any of the PGs?
Now moving on to our second session. Children are the world's most valuable resource and its best hope for the future, as famously noted by John F. Kennedy, former US President, reminding us that safeguarding their mental health is a vital investment in our collective tomorrow. Child and adolescent mental health requires a holistic approach that goes beyond the individual and involves the family, social, community, and multiple healthcare disciplines. Collaborative care and research are essential in addressing the diverse and evolving mental health needs of young people. The next topic is Child and Adolescent Mental Health Care and Research at NGMCRI, a multidisciplinary approach. To shed light on this topic, I invite Dr. Kritika Ma'am, Assistant Professor of Psychiatry and our child psychiatrist, to take us through the session.
Respected senior professors, dear colleagues and dear PGs, good afternoon everyone. So my topic of discussion today is child and adolescent mental health services. Okay. So before going to the topic proper, how many of you believe that children also can have mental health issues or psychiatric issues? Or can it affect only adolescents or adults? Only 2 of you believe that children can also be affected? So, okay. So outline of my presentation is what is the burden of child and adolescent mental health problems, what is the need for child and adolescent mental health services and common disorders we often see, and at MGMCRI what is happening, MOU services we have, awareness programs, some interesting cases, research and reform messages. So burden of child and adolescent mental health Services. We can see from this Indian studies, the community prevalence is around 6.5%, and as per NMHS survey, adolescent mental morbidity is around 7.3%. And you can't believe that suicide is the third leading cause of death among adolescents actually. So before going to the topic proper, I just want to tell about a case scenario. So a 9-year-old male child was brought by mother and uncle with a history of frequent call from school. After the school has been initiated, the child is having some chest discomfort, chest pain, along with tachycardia, palpitations and some uncomfortable sensations, mostly around 11 a.m. in the morning while the child is being in the school. And the child was first initially evaluated in pediatrics and routine cardiac evaluation was done, and it was found to be negative. So while eliciting the stressors, it was found that the child is academically above average child and no bullying was reported from the school. Father staying in overseas but the child doesn't report of missing his availability. And when we were interviewing the child or when we were interviewing the mother or uncle, we were not able to elicit the stressor. This is the most common presentations we often see in child. They often present with some somatic complaints in any of the departments. So less than 12 years being in pediatrics or in medicine. So we have a various method of eliciting stressors from the children, because the children will not tell, I am sad, I am anxious, please help me. They will not use such terms. They will present with they will communicate very differently through some of these symptoms. So one such methods of interviewing is the 3-wish test. So we used to ask children, okay, what are the 3 wishes you would ask when God is in front of you, or genie is asking you some 3 wishes, and the child told, I want to study well and I want to earn well and mother should be free of illness. That's why we were able to found this stressor. The mother was having some chronic respiratory illness and the mother had a recurrent episodes of fainting. So the child felt once the mother is left alone in the home after he comes to school, so something will happen to the mother. So that's the reason the child was having more of this chest discomfort complaint while being in the school. Okay. So what is the need for child adolescent mental health services? So they often present with other specialties and the background of mild anxiety or depression is often undiagnosed. And regarding to the children development, they often believe it's the combination of nature versus nurture. It's that even if the child is genetically vulnerable to have some illness, for example, the child is genetically vulnerable to have some any mental illness, or if the temperament of the child is often difficult also. If the environment is supportive, the child will be able to survive. If the environment is adverse, the child will be finding it difficult struggle. Okay, so there are a lot of environmental influences that happens to the child development. So what we diagnose is more of these neurodevelopmental disorders, emotional disorders, neurodevelopmental disorders like ASD, ADHD, intellectual disability, specific learning disorder, tics, Tourette syndromes. Emotional disorders, most commonly this anxiety and depression, and behavioral disorders like oppositional defiant disorder, contact or problematic internet use, or any substance use. But the most common symptoms they often present is more of like a school refusal, poor attention, decline in academic performance, or any repetitive behavior. And mostly in the depression or anxiety, they can often present with lazy, the child is not doing activities, there was a decline in performance and as school refusal or physical complaints or somatic complaints. Excessive screen time. Sometimes the children who are anxious or depressed can use screen time as a way of coping. So parents only notice that their child is spending excessive time in screen. They will not be able to notice the underlying anxiety that is predisposing it. And any functional symptoms or conversion symptoms you see as pseudo seizures or hyperventilation, etc. And the behavioral disorders like tantrums, aggression, defiance, or excessive screen time. So what is the role of child adolescent psychiatrist in neurodevelopmental disorders? So in neurodevelopmental disorders, what we mean by neurodevelopmental disorders is this intellectual disability, autism, SLD, ADHD, etc. So early intervention is the key. If you are able to intervene early as much possible, the outcome of the child can be better. It is not that we can completely cure the IBD, we can completely cure the autism. Okay. So there is a famous saying by Hebbian learning in 1949, neurons that fire together, wire together. So as much stimulations we are doing, the neurons that are involved in 2 scales. So if you are constantly stimulating, the connections between the neurons is going to increase. And majority of the rapid synapses is going to form in the early 4 years of life, and 80% of the brain development in the initial years of life. So early intervention is going to cause a better outcome in neurodevelopmental children. And apart from the early diagnosis and early intervention, analyzing the skill deficits and appropriate intervention will be provided, and understanding the challenging behavior. Mostly the neurodevelopmental disorder children can have some challenging behavior of biting others, self-biting behavior, aggressions. Okay, we'll be able to analyze the cause, antecedent cause, what is happening, and thereby addressing the challenging behavior, and also addressing the parental stress. Addressing the parental stress has an impact both on the mother, and also it can improve the outcome in the child. Thereby, the efficient mother is able to provide appropriate intervention for the child, providing disability guidance in case of NDD, and in liaison with the school also will be provided by providing feedback to the teachers or providing letter about the students, and what are the classroom recommendations that can be done for that specific child also will be provided. This is another case. 9-year-old child was referred with complaints of hyperactivity and irritability. The child had a normal developmental history and he was performing well academically, and mostly he preferred attending school where he reported feeling happy. The child had previously been treated with risperidone for the behavioral concerns. So when we see if we see the child alone, the child is having more of hyperactivity and irritability complaint. So mostly for any child with irritability, people used to prescribe any antipsychotics or low dose risperidone for the same. But we should not see only the child alone. We have to see what is happening around the child also. So in child psychiatry, it is always the victim. Don't see only the child. What is happening around the child. So detailed history revealed alleged physical abuse and alcohol dependence in the father that had been a stressor for the child, on both as a model in behavior that has contributed to the child's current behavioral concerns. So addressing everything will provide a good outcome for the child rather than seeing the child alone. So for this I want to tell about this Bronfenbrenner ecological theory. So what does it mean is, the individual is the child. So child development is influenced by multiple factors surrounding the child. The first system is the microsystem. Microsystem is the child immediate interaction with whom the child is having interaction with. For example, the home environment, teachers, friends in the neighborhood, etc. Mesosystem, the interaction between the members in the microsystem is what the mesosystem is. So the interaction between the home and the school environment, on the school or with our psychiatric team. So these interactions contribute the mesosystem. Exosystem is this parents, workplace or mass media and other influences that doesn't have direct interaction with the child, but also an influence on the child development. For example, in parents' workplace, if the parent had lost the job, then it is going to cause the financial burden or parental stress for the parent that is going to indirectly influence the child's development. Or the macro system is the widely shared cultural values, beliefs, customs and laws. For example, if the culture is believing that this is normal, this behavior is normal, and seeking a psychiatric help is stigmatizing, it is also going to indirectly affect the child. So these are the systems that is happening around the child that also directly or indirectly can influence the child's development. So this model guides our interventions. Always in child psychiatry, biopsychosocial formulation will do. It is not about what is happening now. What were the predisposing factors? What were the vulnerability factors the child was having? So the child is in the background of any genetic risk or early childhood experiences, adverse childhood experiences or temperament of the child. What is the precipitating immediate trigger? So any recently that has happened had caused the problem. For example, failed in some exams, death of any close members, etc. Perpetuating is the maintaining factors. If there are constant IPR conflicts between parents, mother and father in the family, or there is alcohol use in the father, that are the maintaining factors that is keep on perpetuating the child's complaints. And what are the protective factors? So by addressing everything, we'll be able to strengthen the family's involvement in the treatment. So coming to MGMCRI, we have child and adolescent mental health OPD on all days. From as such, the OPD timings till 4 from Monday to Friday until 1 p.m. on Saturday. And in cases if there is any harm to self or others or suicide or aggression risk, inpatient services are also available as per Mental Health Care Act. And if you are admitting any child, the intimation will be done to the Mental Health Review Board. So we are a team of 9 psychiatrists including 1 child psychiatrist, and we have 2 clinical psychologists. They will do assessments and structured therapy and evidence-based treatments, evidence-based therapies. And a social worker who will be able to provide the guidance on disability or CWC referral as needed. At NGMSRA, Per year we have 800 to 1100 consultations per year. Number of school visits as an outreach program we do 4 to 5 schools per year. And number of children screened outreach is 100 to 150 per year. Awareness programs 3 to 4, and mostly majority of the reference for child psychiatry is from pediatrics and 10 to 15. And many thanks for the reference from all of the departments. So if we see the child psychiatry census, there is a rapid surge of child psychiatry cases in 2022 post-COVID era, which was really surprising for us too. And apart from that, there is an increasing trend of child psychiatry cases over the years. And we have a MOU with Vishay Francis LFIP school in Pondicherry. So twice monthly visit will be done to screen children at risk and assessments as needed. And we will provide recommendations and interventions to the parents and teachers in the school, and the quarterly review of activities will be done with the team. Another MOU with the SOS Children Home in Kilmambakam. So there awareness about common mental health problems was provided to the caretakers of children's home. Development of questionnaire to identify children at risk was done. An IP assessment for all children, for around 90 to 100 children was done by our clinical psychologist. And children will be brought for consultation periodically to the department from that home. So then many awareness programs have been conducted over the last 15 years. One such program from Satya Special School for awareness programs to parents. These are some pictures from awareness programs conducted in Clooney School, in St. Joseph School, in Aristo Public School, etc. From all of our team members, including psychiatrists, psychologists and social workers. With the liaison with the pediatrics department, so from child psychiatry, major reference we are getting from the pediatrics department, and we have a separate child guidance clinic which is operating on Wednesdays from 2 to 4 p.m. It is in the I block, first floor. So who will be seeing is the child psychiatrist along with the developmental pediatricians, speech therapists and psychologists. So I want to tell some interesting cases what we have handled in child adolescent psychiatry. This is a case, this is a 6-year-old male child. He complains of hair pulling since 3 years of age with patchy hair loss. This is what we call as trichotillomania. Trichotillomania is very common, you would have heard, but having since the early childhood, from the onset from toddler, is very atypical. Okay, so the child was having this complaint for 2 to 3 years. So after evaluation, he was referred from derm, and we evaluated and he was found to have trichotillomania with comorbid ADHD. So with the habit reversal therapy plus medications for both of this, the child had improved. So initially during the presentation, the child was having hair loss with hair pulling with patchy hair loss, and after at the end of 12 weeks, the child hair was started to grow and he was not plucking the hairs after 12 weeks. This is a case, this is a 13-year-old neurotypical child. It was a known case of myomania on irregular treatment. He had a history of febrile illness with vomiting and headache, and he was admitted in Department of General Medicine here. And the fever and vomiting had subsided, and he went back home. But 1 week after, he had an abrupt onset of behavioral disturbances, including irrelevant speech, irritability, sleep disturbance, suspiciousness. And in psychiatry findings, we found excessive speech, irritable affect, persecutory ideas, delusional misidentification. Delusional misidentification, he was having Fregoli syndrome. He will identify unfamiliar persons as a familiar persons. That's what we call as Fregoli syndrome and auditory hallucinations. So initially, in the background of this disease with the abrupt onset, initial evaluation to rule out other things, autoimmune, Wilson, Sézary, everything was done, and it was found to be normal. And imaging initially they told it's old myomania disease. But after the evaluation and getting the neurologist opinion, it was found the progression of the myomania disease had happened with this collateral formation, which has contributed to the symptoms. Then the child was referred to Chennai. The child was operated in MGM Healthcare, and in post-operatively the child had these psychiatric symptoms for 2 to 3 weeks, and in 1 month the child attained a premorbid level of functioning. So this is about how the organic conditions or brain lesions can present initially with the atypical psychiatric symptoms in children. This is a case of ASD with psychosis. This is a 13-year-old male who had been diagnosed with autism since 8 years of age because he was having complaints of physical unprovoked anger, physical aggressions, decreased interactions, decreased eye contact, poor emotional reciprocity and no sharing of interest. So he was diagnosed as being autism and he was undergoing speech and occupational therapy for the same. So for around 3 to 4 years. So after evaluation it was found the symptoms onset is only after 8 years of age, which is atypical in age. ASD onset will be in the early years, 1.5 to 2 years of age. So the diagnosis was revised to early onset psychosis and was started on treatment, and the child had responded well to the treatment. The child had improved in eye contact, speech, interaction, sleep disturbance, everything, only for the cognitive impairment that has happened for the years last for the 3-4 years. So ongoing PG research on brief caregiver mediated intervention for behavioral problems in children with ASD. In Satya Special School we are doing. In Satya Special School there are many special children whose caregivers are not seeking treatment. So we are going and providing some caregiver mediated intervention to handle the behavioral problems in the children. That is done by our postgraduate Dr. Nisha. It is interdepartmental with the Department of Community Medicine. Another thing is the impact of internet addiction on cognitive function in children with ADHD. So ADHD has some cognitive impairments. We want to see the impact of internet addiction on this cognitive functioning by our PG Dr. Sarvaganapati. So when we see the child adolescent mental health problems or services, the problems we are always facing from even the parents or my own colleagues is that failure to identify by parents, or they have stigma. If you say that, okay, go and get a psychiatric opinion, parents will feel a lot of stigmatized and they are hesitant to come to psychiatry for the consultation, and they have a preference for alternate treatments. If you are providing some medications, they'll be like, okay, can we try homeopathy or this flower medicine, etc. So more preference than for alternative treatments than the evidence-based treatments. Medico-religious medicine, taking the child for medico-religious treatment apart from the treatment provided for evidence-based, and delayed referral from school. From school, the academic difficulties are often found late, around the 9th standard or 10th standard. If the child has been referred earlier, we could have done some interventions that would have benefited the child. Okay? And there are multidisciplinary service shortage in rural areas. We are telling them go for speech therapy or occupational therapy. If they are coming from a remote village, we are finding it difficulty for referring them. So why should every department care? So the most common presentations from pediatrics are developmental delay, somatic or functional symptoms, dermatology, trichotillomania, skin picking, neurology. All these neurodevelopmental disorders are functional symptoms like pseudo seizures, medicines from medicine, adolescent depression, self-harm, unexplained somatic complaints, and OG. So many people are thinking, okay, child adolescent mental health services, at what age it starts? It even starts from your antenatal period. When we are pregnant and if we are very stressed, that itself can cause problems in the child development. Okay, so mother-child bonding, stress assessment during antenatal period. So in the early, so antenatal period assessment, stress assessments. Then the immediately after delivery, postnatal, the mother-child bonding. Okay, so that also under OG. So take-home messages is no direct typical presentation as per criteria we can see in children. Okay. They always communicate differently through the behavior, through any somatic complaints or self-injurious behavior or excessive phone use, etc. So don't look for the answers in the child alone, what is happening. Always look for the answers outside the child, in the immediate family or school environment. Biopsychosocial approach will help the child, and by treating them it shapes the child's education and thereby the future of the child. So these are my references. Thank you.
Very nice presentation. So I would like to take on record that the appointment of Dr. Jessica as child psychiatrist 2 years ago was a big shot in the arm for the department. So we've been really able to expand our child psychiatric services. And if you recollect the chart that she projected a few slides ago, it was in the last 2 years that we've really been able to boost the CAP census also. So that's quite remarkable. Now, the professor level here, Dr. Abdepan, who's supervising the child and adolescent psychiatric services. So, would you like to add on?
The question she asked at the outset is the most important thing. When the earliest, almost 100 years ago, it was thought that children might not have any mental illness because they lack the theory of mind. But in the last 20 years, it has understood that most, if not all of the mental health problems are neurodevelopmental in nature. What we see in the later ages, like even depression, anxiety, all these are predisposed and precipitated by childhood developmental conditions. So any intervention done in the early part of the life is definitely going to affect the trajectory of the development. And child and adolescent services is one of the hardest services in psychiatry because it involves the entire family. We should not, we don't deal with one person, but we deal with the opposing views and the stigmas of many different persons. So that in that way, the work done by and then the department is very commendable. And we would even like to expand our services and would like to invite more referrals, especially the postgraduates. Definitely you can, if at all you are able to identify a problem side in either under your care or under someone of your some patients side having an issue, definitely you can refer to our department anytime. Thank you.
Thank you, Dr. Invite questions from these.
It's not the questions, I just wanted to supplement what Ritika mentioned, that although the title says that what you can say is a question that how many of you believe that there is psychological problem in the children and the youth. As you know, like initially only psychiatric problem is to think of adult, right? So now gradually we are coming down to the child and adolescent. Now as I rightly pointed it out, even as you know, like it depends on the mother's psychology itself. When a mother is pregnant, during that time, as you know, lot of hormones, although it's a physiological phenomenon, mother undergo lots of psychological stress due to many factors. And of late, I think recently we have conducted with the initiation of FOXY, they are initiating that all the pregnant women should undergo psychological screening, and if they found to have something, then it will be treated also. Because because it may affect children also. So that is how what you can say where we are going. Like so, prevention does not, screening does not start only at one thing. Recently, like 2 days back, I was attending on pediatrics. I think PAPS coming up with that neuron, something you told, neuron bias and bias. Fire together, wire together. Right. So that means how early the psychological or the neural stimulation should start. Right. So they say from the beginning itself. As soon as the child born, that neural stimulation should start, so that by the 12th, that is related to different issue. So and rightly she pointed out the bonding. One of the major factor what we are like after becoming dean, I think almost every alternate day I have to counsel one or two MBBS students, right? So now when I go back and find out what is the reason, again it comes to the family only, right? So what I wanted to tell you, like this talk might have instigated all of you analyze your family situation, right? So how you were brought up, and suppose you have some stress factors, and in which way your family is responsible, and how to rectify that one, right? So this is a very important topic, and thank you for bringing out this issue.
Thank you, sir. I completely agree with what Dean sir said. Actually, how I've heard experts say that how well a country does and how well we progress depends upon how well we take care of our pregnant women, because that determines, the future actually, both the physical and the mental health of the pregnant woman. So, any questions from the audience? Does anyone have anything to put forth? Yes, please.
Hello, ma'am. Myself Naveen from me. I just have a doubt, ma'am. You are initially telling whether the children are expressive. Children, they don't tell it out. Yeah, I honestly accept it, but they express it in some way. And you are telling about the stressor points, no? Yeah. And we are actually noticing in my OPD, we are seeing parents coming and telling to us that they are using mobile phones frequently. They are not going off the screen. All these things we are seeing actually. I think after people also will be accepting this. So can you just tell us some points where we can identify the pediatric wards, where we can initially access, or what are the points where we can know they are psychiatrically affected in a way?
Any recent change in behavior that is happening, sir.
Okay.
If any recent stressor that has happened that has caused this change in behavior, that is one thing. And if the child is using mobile, but in a stipulated time, it's not causing any of the impairment and it's not amounting to addiction, then it is okay. But it is taking away the child's time and then causing impairment in child's education or interaction, then we have to intervene. Yes. And apart from that, we can always ask, okay, in whom you are noticing these complaints. In the school, are you receiving any more complaints? Okay, so in the school context also, we'll be able to analyze how the child is in school, is it sleeping, are there any changes in the performance of the child. So related to phone addiction, we can ask these questions.
So if we find anyone like that, is it okay we refer the
Sure,
patients?
you can refer, sir. Because many of the parents want interventions for actually internet addiction or excessive screen time only. So sometimes it lies with the child or the stressor, sometimes it lies with the parents. The parents are being permissive or they are giving phone excessively.
The stigma part is also the true one. Some people, they are not willing to accept it.
Yes, sir, that is the problem we are facing every day in our OPD. Okay, as soon as I come, why am I being referred? I came with a complaint of headache, hyperventilation, chest pain, but why have been referred to psychiatry? So you can initially psychoeducate and tell the rational behavior and you can send, sir. We also will do.
Yeah, sure. Thank you.
Thank you. Any other questions from the audience? Dr. Kritika, I wanted to ask you a couple of points. Recently there's a lot of media coverage about examination stress causing a lot of distress, especially 10th, 11th, 12th, and the competitive exam. Have you seen such cases in our OP or IT setup, and what is your experience with regard to it?
Yes, sir. We have seen many such cases, particularly around the February, March month. As is the nearing the exams, particularly in 10th and 12th standard before the board exams. So often they will present directly with the exam related anxiety, and we had some case who presented with nearly catatonia in the exam related stress. So in different presentations they will come to the OPD. So based on the time we will plan the management of the child, sir. So initially if it is in the mind, we plan for psychotherapy for the child. Or if it is along with medications, we plan therapy for the children, sir.
The second point was about, again, a lot of media coverage about gadget use, especially AI use, and how it's affecting the mental health of children these days. And they are very, very young. So have you seen such cases in our OP? What is your experience?
So only with the gadget use, people are not being coming here. So I don't know like what is the lack of awareness in the parents that is happening. Only if it is causing much of the impairment, if the child is not giving away phone and the child is getting irritable, the phone is snatched away. These are the most common complaints that often come. So we will try to intervene in a way like we will assess what is the screen time. Are there any background anxiety or depression that makes the child to do as a part of coping whether the child is using screen use. Okay, we will educate the child about the consequences of phone use. We will sit with the parents and we plan for the parent management techniques. Okay, how the rules can be framed, the setting up the limits, and the parental apps that parents can have to monitor the children gadget use. That a lot can be fixed.
Thanks a lot, Dr. If there are no more questions, I'll hand over to Nancy.
Thank you, Kritika ma'am, for your informative and insightful presentation. Thank you everyone for engaging in the discussion. We now come to the third and final academic session of today's grand round. Tobacco use continues to be a major public health concern, and effective cessation often requires coordinated efforts across different healthcare services. A well-integrated referral system and collaborative care can play a crucial role in helping individuals achieve and sustain tobacco abstinence. Now I invite Dr. Kadir, Professor of Department of Psychiatry, to present about Tobacco Cessation Center, MGMCRI, referral mechanisms and collaborative services.
Good afternoon to all the gathered here. I myself, Dr. Karthik, am representing my team members here to show some of our salient services which we are providing in Tobacco Cessation Center in MGMCRI. As the MC rightly pointed out, the context of this presentation is regarding the burden which it poses in the community. Like it has around 30 to 35% prevalence, that is tobacco dependence in the community. And when it comes to hospital setting, it nearly doubles up. So almost 60 to 70% of the patient population have had one exposure at least to tobacco product. And it is so common that it has become a regular field in history taking of about substance use, alcohol and tobacco. And it is so common that many patients have been referred to psychiatry for alcohol problems. It is true because this substance use influences the onset, progression of many medical illnesses. It also impairs the recovery in many surgical processes. So it has become a major source of death. But tobacco use as such has got less attention, so we wanted to project why it is more important. Before I go into the full details, I would like to mention about what are the salient tobacco cessation initiatives taken out by Government of India before this major TCC event, and how we evolved in MGMSARI from Smoking Cessation Center to Tobacco Cessation Center. Even though it sounds like a name change, it is a different change. And who are all the constituent departments in TCC, and finally what are the services we are doing. We also want to mention some of our future plans, how we want to expand our services. So, yeah, it started off with the Cigarettes Act in 1975, which banned unrelated procurement or use or distribution of tobacco products. It also mentioned the statutory warning labels on tobacco products. And a couple of years later on, it restricted advertisements. Those days it was cable TV. So cable TV ads were regulated and all these things were banned. 2000s saw the advent of smoking cessation or ban in public places. It was a landmark ban. It was initiated by the Supreme Court of India. In 2003 also there is a landmark act which was enacted by the Government of India. It's called as the CORPA Act. It is the Consumption of Tobacco and Other Related Products Prohibition Act. So after that there was a major ratification, that is India aligned with the WHO ratification of tobacco control, and all the countries were actually requested to draft a plan or policy to curb tobacco use in their own nations. So India worked on it, and it worked on it for a couple of years. In 2007, they came up with a plan called as National Tobacco Control Program, which is continuing to this date, and it has been the backbone of various cessation-related activities, like ensuring how education institutions can stay tobacco-free, what are the guidelines to be framed for them. And we are seeing some statutory warnings in TVs, in cinemas. So all these things start off after this program, and their plans are expanded. And now we are in the age of digital media regulation, and so there are guidelines. So this is the broad context of what are the initiatives taken by the Government of India. It is also important to stress that there is an integration of this National Tobacco Control Program. To ensure this financial sustainability, it is integrated into the National Health Mission. So NTCP can witness circulars, orders from National Health Mission directors, deputy directors. So that's how it gets getting continued year by year. At the same time, it is also integrated with the grassroots levels, that is the Panchayat Raj, local administrations. So whatever plans and programs are initiated, it will eventually reach to the beneficiaries at the grassroots level. So that such is the integration, and that is why this program is being able to continue almost for more than 2 decades. So there is an apex center called as the National Tobacco Control Cell, and another center called as State Tobacco Control Cell, which is there in all states and union territories. So in 2024, that is a couple of years back, during the World No Tobacco Day commemoration on May 31st, Government of India pushed for or even asked medical institutions across the nations to open up their own tobacco cessation centers and just not rely on the government architecture alone. So the medical institutions were given certain guidelines to start off this TCC in short. And thanks to the Department of Government Medicine and their spearheading efforts, that they initiated this way longer. In 2018, during the World No Tobacco Day and World COPD Day, they initiated the Smoking Cessation Clinic as a service. We were one of the contributing departments at that time. And over 6 years, we have been running in their department. And after that Government of India initiative, we had to make some drastic decisions. Apart from the name change, improve the data census, to maintain data records, to improve the service support, recruit more people, especially psychologists and social workers dedicated for this thing, and also review all this progress, present this review progress to the state tobacco control cell. And now it has been going on every 3 months. So now it has become a regular activity in this tobacco cessation center. These are some reminiscences. In 2018, we initiated the smoking cessation clinic under Department of Pulmonary Medicine, and it was the initial setup with a small group. And National Tobacco Control Center and also this STCC, they demand that it has to be conducted on all days. So we shifted the clinic to Department of Psychiatry, and it is open on all days and all working hours. So that thus came this Tobacco Cessation Center, which is a integrated setup run by Departments of Psychiatry, Pulmonary Medicine, and also Community Medicine. Community Medicine Department helps us tremendously in form of their outreach activities, awareness programs, and early prevention strategies, which I will be telling you a little later on. So when a patient reaches in DCC, it is usually a referral from another department. 95% of patient contact is through referrals from the parent department. It is rarely that they come only for smoking cessation to a psychiatric center because of a number of reasons which Dr. Kritika already told you, about the stigma and other things. After an assessment by the faculty and PG, based on their severity, based on their motivation status, and based on their preference, the treatment can vary with both medical interventions and psychological interventions, or only psychological interventions, just support and counseling services. But whatever be the intervention, we are striving to ensure that they are staying in follow-up, because tobacco use is as such as a habitual disorder. So we can understand that it's having a factor called as recurrence, which is highly possible. So we strive that they are in the loop. So when we look back at the census of that TCC, before I show the actual census, we need to understand that there are some key feeding departments. Next to Pulmonary Medicine Department, we have departments of General Medicine, Master Health Checkup, and we also have other departments like surgery, sometimes even medical oncology, neurology, who are referred to us for smoking cessation based on their targeted outcomes for post-surgical interventions, for any treatment with drug-drug interactions, they were referred. So in order to streamline, in order to enhance that consistent feeding into this TCC, we have come up with a solution or a strategy, I might say, that this screening can happen regularly for all patients, at least in the key departments, Pulmonary Medicine, General Medicine, Master Checkup, and only 2 questions. Is there use, and are you willing to go to a TCC center which is available here? It is a very key step, because when the parent department and the treating doctor says that it is important to have a consultation for tobacco cessation, it really works a lot. And I can show you in this graph also. So this screening procedure or this screening procedure started only in January 2026. So after the procedure, the census has consistently improved. So this is not false data, this is not real data, and it is dynamic actually. The last cell, July 2026, it's a dynamic column, it's still increasing. So these are the common services which we are providing here. In medical interventions, we don't provide them tablets or something, but nicotine is one substance of addiction which can be replaced with a lesser harmful preparation. So nicotine in the form of patches or gums we used to give to the patients to overcome the withdrawal phase very easily. And in order to ensure the consistent supply in all the medical institutions, the Government of India, apart from pushing us to have a TCC, they also give us 1,000 free samples every time when we request. It's not like 1,000 free samples for 1 month or 3 months. So as of when it is expiring, we can ask the state tobacco control cell, and we have been procuring it regularly by using a separate mechanism. And our director of hospitals have been supporting us in getting these things regularly. And in counseling services, which is one of the most favored therapy for many of our patients with tobacco use disorder, they have been given brief intervention in the form of the 5 A's and motivation enhancement and relapse prevention. The psychiatrist or psychologist's role comes in the later stage, that is the motivation enhancement and relapse prevention, because the first part is already done in the key department, because asking and arranging for a referral is the most important parts. and comes the extending arm of community medicine in public health promotion. And public health promotion wise, Department of Community Medicine has been able to conduct over 9 school awareness programs, 3 college awareness programs, and over 36 public awareness programs, and 4 competitions over the last 1 year alone. This was after the initiation of this TCC and the regular audits by the State Control Cell. And there's been an unwavering support from the Community Medicine Department. These are some images which I can tell you that one, the left side is the poster competition for nursing students. So we want to disseminate this information in nursing domain also. There is a pledge taking for UD students and distribution of awareness pamphlets to the general public in the hospital lobby. All these are in the context of World No Tobacco Day commemoration. And when it comes to early prevention, I think school population, especially the adolescent population, is the most vulnerable population. So community medicine, by means of their existing mechanisms and liaison mechanisms with the school authorities in Pondicherry and Kadlur, they have been able to deliver this as easy as possible. And there also, we have been able to conduct interactive programs like quiz competitions, drawing essays competitions, and a wide range of public, starting from general people, public, and also to targeted workforce such as construction laborers, migrant laborers. We have been able to access these vulnerable populations and deliver our health education activities. This is the most recent activity, a poster and quiz competition for school students in Umarmangalam, Bahur Road. And this has featured in the local daily also, and we have been able to get a name for it. This is another activity, it's a modest activity where PGs and UGs were requested to have a competition, in essay writing competition for World No Tobacco Day, and of them certain people got certificates also. So apart from medical counseling and public health promotion, we wanted to see the real picture also. So we have another contribution, that is a research contribution, where we are looking at the readiness and challenges in patients who are trying to quit in tobacco use. So there is a PG thesis on the same topic. Again, this is in collaboration with Community Medicine and Pulmonary Medicine Department. So looking ahead, we are trying to improve the referral rates. We are also willing to provide consistent support. So we are well aware that if we are asking only for census and the n number of patients land up in our OPD, our support may become inconsistent. So we are looking at various strategies to provide consistent support even to the nth number of patients who visits on the day for tobacco cessation. And we also want to expand outreach services by providing more and more of early intervention strategies and other things to club with other substance of abuse also. So we'd like to thank our dean, sir, because he was one who was staffed of the committee when 2024 the government of India launched this program. So under his chairmanship, we started up the committee, and we would like to thank all the HODs, faculties, PGs of all the clinical departments who have been referring to us, and also the interns who played a key role in outreach activities, including skit programs and others, and also the nursing staff of OPDs who are keen enough to put the seal and the channel is for tobacco screening. Thank you. Thank you.
Thanks a lot, Dr. Karthik. It was a very illuminating presentation. So 2 years ago, as Dr. Karthik said, when the government ordered all the medical colleges to go ahead with this initiative, so from our side, Dr. Karthik was appointed as nodal officer representing the psychiatry component. So since that day, Dr. Karthik has been doing amazing work in this area, and recently we added Dr. Gokul also, assistant professor, and we have our clinical psychologist and our social worker playing a very big role with regard to the TCC. And we have incredible support from community medicine and pulmonary medicine also. So thanks Dr. Karthik. And any questions from the audience?
Number of census. How many female?
Yes, female patients we are not able to get in the hospital sample, but in the communities, in the community screening, they were able to willing to come forward and say that they have been using smokeless tobacco, which is the most common in female population.
The data you have provided, every time there is new cases.
Yes. There's no repetition in that sense.
Success rate.
Yes, that is the main drawback of our current system. While we are providing the service delivery, we are trying to ensure the follow-up rates, retention rates, and we need more further data to tell how many of them actually are quit, how many of them are actually doing well.
Thank you, Sarai. Now, what I wanted to emphasize is that although the effort to further tobacco cessation has started way back in 1975, almost 50 years gone, right? But still that we are struggling, and rather to say the prevalence is increasing day by day, right? So, what is like how basically I know like this may be difficult. Where we went wrong, why even if the Tobacco Act was started in 1977, still it is not working. Like
short answer is like I guess multiple factor related. That is the personal psychological factors also have changed over these last few years. The stress which they are exposed to, the early vulnerable population, that has also increased. Whereas on the other hand, the regulation of the substances by the political organizations or the government agencies, that has come down. And only of late, we are having increased awareness after the WHO ratification in 2014. So we are increasing the screening. But as my psychiatrist will understand now, tobacco has become like a sort of a gateway drug. It is just a first drug. Now it is open up to other drugs options. So the problem is even more higher compared to only tobacco use. So we want to try as much as possible because it's widely available and affordable. We want to curtail as early as possible.
Dr. Karthik, has the PCC had any impact on the student community? Is there any relevance to helping students?
So that's what it's a different, it's a diverse problem. When it comes to colleges and other things, tobacco has already been there. Tobacco has already acted as a gateway drug and now they are into other substances. But when it comes to a rural population where there is only schools, it is still a target. There is still an active target of control. So, the student mental health community is definitely high compared to a general population community. It is increasing daily.
Thank you, Doctor.
Thank you.
If there are no more questions, I'll hand over to Meghna.
Before we end the session, I would like to invite our Dean Sir, Dr. Satish Ghosh Sir, to share his concluding remarks.
So basically, as you know, like the 3 days discussion was there, and 3 days were brought about 3 different issues. First one related to alcohol. All of us accept